I'd like to just congratulate all the team API to have concluded such an outstanding CME. Very well conducted conferences, which we have lectures we have seen today. Today I have been allotted the topic of peri and post-operative management of diabetes. As I was discussing with PK Jain sir, I was thinking that it would be much more beneficial for anesthetist and surgeon, but I don't find any anesthetist surgeon today now. However, all the physicians are here. I hope you will be finding this useful. Today, if we talk about this topic, why we should be worried about pre-operative sugar control. So it has been found that diabetic patients, they require more surgical therapy as compared to non-diabetic patients. Now, pre-operative hyperglycemia, if present, will not only increase the length of stay, it will delay the wound healing, it will increase the rate of infection, even surgical site infection, increase ICU admission, patient might land up into severe conditions like DKA, hyperosmolar states, and will have high post-operative mortality even after discharge. So these are the things which can be seen, and hence it is really essential that pre-operatively we should be controlling our glucose. So to make things interesting, these are some case scenarios which we can encounter practically. This first case, this is 36-year-old male who has been admitted for bowel perforation peritonitis. His sugars are 325. However, there is no past history of diabetes in the past. His HbA1c when done was found to be 5.8. So what does this imply? What is this case? His HbA1c is normal but sugars are on a higher side. These are the common scenarios which you can see in our day-to-day surgical procedures also. This is stress hyperglycemia, and it is not very uncommon to see in stress hyperglycemia in routine practice, and incidence is as high as 12 to 30%. Now 60% and out of those patients who develop stress hyperglycemia, 60% will become diabetic in a year. So we should measure HbA1c on admission to differentiate whether this is stress hyperglycemia, diabetic, uncontrolled or not. So surgical stress per se has been shown that it might increase the counter-regulatory hormones, catecholamines, glucagon, and ultimately lead to increase in the glucose. So in these scenarios, we can give small shots of insulin. Sugars still needed to be controlled because pre-op sugar control is required, and small amount of insulin, and we can take up the patient for surgery. Now again we have literature where you can see that stress hyperglycemia, if found that if glucose on the higher side, the rates of complication, if glucose is between 140 to 180, odds ratio was found to be 1.68. If glucose is more than 180, odds ratio was as high as 6.56 in terms of complication and mortality. Next case scenario, this is 60-year-old male admitted for total hip replacement for AVN, and he has no history of diabetes, but BMI is quite high and has history of obstructive sleep apnea. Now we find that patient sugars are on higher side, his A1C is again on very high side, 15%. So this is again a common scenario which we generally see in our region also. That is the case of undiagnosed diabetes. They were diagnosed only when they got admitted for some elective surgery or they developed fracture or road fracture accident. That time they got admitted and then found to be undiagnosed diabetes. Now it has been found that complications are much higher in undiagnosed diabetes as compared to diagnosed diabetes, and hence we should ideally be delaying this case if only if it is an elective procedure. If it is an emergency, we can still proceed on by controlling the blood glucose. But for an elective, undiagnosed, very high A1C, we should be delaying this procedure. Next case scenario, where this female got admitted for total abdominal hysterectomy. She is no case of type 2 diabetes on oral drugs. Her sugar was on a higher side. When HbA1c was ordered, it was found to be almost on the target range. So how should we proceed? Should we delay this procedure or should we continue? So as the A1c is normal, but sugar is on a higher side, this is again stress related, might be stress related or anything other related. That time we can again control the blood glucose, make it less than 180 and then proceed for the surgery. Next other case scenario which we can see is this like male admitted in ER for left foot gangrene, known diabetic, known CAD, underwent angioplasty. His sugars are on higher side, A1C on higher side. Should we delay this procedure? So ideally, this is an emergency procedure. Again, we can go on to proceed with this surgery, provided we should control the blood glucose immediately. Best would be to start him on insulin infusion. So coming to with this case scenarios which we can encounter, coming to our main topic, that is pre-op management of diabetes. When considering a diabetic patient for surgery, it is essential that we should determine that patient is which type of diabetes, is he on diet, is it controlled or not, what complications is he having, is he going for a major surgery, minor surgery, or it is an emergency surgery. Goals of glycemic control is not only to control the blood glucose, but also we should be avoiding hypoglycemia, DKA, and managing fluid balance. ADA recommends that glucose range for pre-op should be between 80 to 180. Other diabetic guidelines are also in a similar range, that is 90 to 180. Intensive glucose control was seen where less than 120 glucose was targeted. However, it was found in studies that there was no much improvement, and hence ADA has come up with a wide range, that is 80 to 180, where we can target our patient to be between 80 to 180. Ideally, if a diabetic patient gets admitted for surgery, we should be offering these tests which are recommended: random blood sugar, A1C, ECG and creatinine at the baseline. If any abnormalities are found, we can go on with a further investigation. However, these are must. If A1C is less than 8%, generally surgery will go well. If more than 9%, there is high risk of surgery, and ideally if it is an elective procedure, we can delay the surgery, and if not, in an emergency case, we can go on with the surgery. Now these are some drugs which the patient might be on once the patient comes to us for surgery. These are some oral drugs which are available. You can see that SGLT2 inhibitor, it has been said that on day before surgery we should be omitting the dose. However, other OADs can still be continued. This is because SGLT2 inhibitor causes hypovolemia and can cause euglycemic ketosis, especially in stress-related scenarios like surgery. And hence, patients on SGLT2, 2 to 3 days prior to surgery, we should omit the dose. Next, DPP4 inhibitor, on the other hand, is found to be quite safe. So it has been even on the day of surgery, we can continue DPP4 inhibitor. However, other drugs like metformin, sulfonylureas, all SGLT2, all has to be stopped. Now for pre-op management, if patient is on OHAs, sugars are well controlled, OHAs can still be continued but omitted on the day of surgery. If sugars are on higher side, it would be best if we put the patient on basal bolus regimen. Premixed insulin again should be avoided because there are a lot of hypers and hypos. This is not a regimen. This basal bolus is more physiological. However, premix will lead to more hypers and hypos, so not advisable. Basal bolus would be best. Now about the sliding scale, now this sliding scale has become obsolete and should not be used in pre-operatively. There are multiple RCTs and one meta-analysis of these RCT comparing sliding scale versus basal bolus or basal plus. It has been found that glucose concentration with sliding scale was found to be much higher, plus rate of complications were found to be much higher with the sliding scale. So if you are initiating a basal insulin and patient is on OAD, we find that sugars are on higher side, we can either put the patient on OAD plus basal. So if we are going to start basal, we can start with 0.2 units per kg. So for example, a 60 kg individual who is uncontrolled on OAD, we can start with 0.2 into 60, that is 12 units of basal insulin. Usual dose, so this is on patients on OAD. Now if the sugars are very highly uncontrolled, we can start on a basal bolus regimen. So how to calculate a basal bolus regimen in a patient who is admitted? Usually we can directly use the factor 0.5 units per kg in a normal patient. However, for resistant or steroid, we can go on with a higher dose. So for usual dose 60 kg, 30 units of the insulin in a day will be required. 40% can be given basal, 60% can be given bolus. So for a 60 kg individual, total daily dose for as will be given by 0.5 units per kg would be 30 units in a day. 40% could be given, that is 12 units in the night. 60% of the total daily dose of the 30 units would be 18 units would be given divided dose. So we can give a prescription as regular insulin, acropate, liscoaspart, any of them, either 666, or we can give more in the afternoon, some and less in the evening, according to the food intake of the patient, and basal insulin at the night. So this is how we can initiate a basal bolus regimen. Now on the day of surgery, it has been said that if the patient is on long-acting insulin, we should ideally reduce the dose of insulin by 20%, because that long-acting insulin might cause hypoglycemia on time of surgery, and hence some amount of dose should be reduced. On morning of surgery, ideally we should be omitting. If the patient is already on 2 times insulin, like 2 times NPH, you can give 50% of that dose of the insulin in the morning. But for emergency procedures, we don't use basal bolus because that might take some time. Best would be to start IV infusion. So commonly followed algorithm is, if the patient, you can calculate by initial rate of insulin infusion by dividing by the blood glucose level by 100. For example, if sugar is 400, just divided by 100 units, 4 units per hour, you can start with the infusion. And there are multiple algorithms available by which you can add on or subtract the units per hour infusion. Intraoperatively, goal is again to maintain blood glucose less than 180. Intraoperatively, surgeries of shorter duration, less than 4 hours, it has been recommended that we can still use subcutaneous correctional insulin every 2 hours along with regular blood check. However, surgeries of greater duration and surgeries involving lot of fluctuations in hemodynamically, extensive fluid shift, we should start with insulin infusion. Now post-operatively, again we face challenge. This is one because of surgical stress leading to increase in the counter-regulatory hormones. Patient on medication might be on steroid, might be some anesthetic drugs which are interfering, or some nutritional changes, patient might be NPO or be having a vomiting issues. So these are the challenges which we might face. Again, post-op sliding scale is not acceptable. We can start the patient post-op once or twice daily, long-acting insulin, along with prandial insulin. This will be the most acceptable regimen. So if patient is NPO, so you still need to give some basal coverage of the insulin. 0.2 units per kg of the insulin could be given either once a day or twice a day. And once patient start eating, you can start prandial insulin 0.2 units per kg. So post-operatively, if patient goes in ICU, you have to give IV infusion. If patient is in non-ICU, you can start basal bolus. If patient is taking enteral tube feeding, this type of patient you will need to give basal coverage. So you can give 2 times NPH. Total parenteral nutrition, you have to neutralize that solution. So you can give for every 10 grams of dextrose, you can add 1 unit of insulin, 230 pm. Or there is another method that you can give 80% of the total daily dose of that patient in the total parenteral nutrition. So with this, I will just conclude. There are some take-home messages from my slides. 1, pre-op evaluation, you should be doing a RBS, HbA1c, creatinine and ECG. Pre-op glycemic target is between 80 to 180. Oral agents, SGLT2 inhibitor is to be stopped 2 to 3 days prior to surgery. Other OHAs to be omitted on the day of surgery except DPP4 inhibitor, which is being recommended, we can continue. Basal insulin is to be reduced by 20% 1 day prior to surgery. And it is always ideal to put basal bolus regimen pre-operatively, especially if the patients have uncontrolled sugars. Sliding scale is obsolete. Intra-op target blood glucose is less than 180. Post-op, again, we should consider basal insulin when NPO and consider starting a prandial or a nutritional insulin then patient resumes eating. Thank you so much. And the questions or queries are welcome.
Thank you, Dr. Anshul, for an excellent talk. The essence is that during operation, the blood sugar should be kept below 180 as far as possible. Surgeons referring the patients to me कि साहब ये आप pre-op control कर लीजिए. The biggest culprit to my mind is an ophthalmologist. वो तो बिल्कुल 180 के पीछे ऐसे पड़े रहते हैं. अगर 181 भी होगा तो नहीं साहब अगली बार करेंगे ऑपरेशन. क्या इनके दिमाग में है मुझे नहीं मालूम. The second biggest culprit is a gynecologist. सर्जन बिल्कुल धाकड़ होते हैं. अरे साहब तो 250 हो जाए 300 हो जाए हमें कोई फर्क नहीं पड़ता. So the idea is that what you probably not emphasized. ठीक है 80 to 120 या 120, 150, 180 होना चाहिए. लेकिन प्रैक्टिकली अगर हम देखें तो समझ में ये आता है कि विद द एडवेंट ऑफ ग्लूकोमीटर्स ये सब चीज़ें बहुत बेमानी हो गई. मतलब एक जमाना था जब ग्लूकोमीटर होते ही नहीं थे. जब आज की भाई सर्जरी करो ये करो वो करो. अब आप शुगर करा रहे हैं और शुगर जो 2 घंटे में आ रही है. अब तो इंस्टेंट ब्लड शुगर अवेलेबल है. आप शुरू करिए ऑपरेशन. कोई भी सिचुएशन है कैसी भी सिचुएशन. नाउ द क्वेश्चन इज दैट व्हेन यू वांट टू स्टॉप SGLT2 इनहिबिटर देन ओके थ्योरेटिकली ठीक है. लेकिन प्रैक्टिकली आई हैव नॉट सीन अ सिंगल केस ऑफ यूग्लाइसेमिक कीटोएसिडोसिस. 5000 पेशेंट्स ऑन SGLT2 इनहिबिटर. होता ही सब कहने की बात है. 5000 मरीज हैं इस समय SGLT2 इनहिबिटर डेपेग्लिफ्लोजिन और इसमें. दैट इज नॉट अ सिंगल केस. और मेरी अपनी आंखें बंद नहीं मेरे कान खुले रहे. सो द ओनली प्रॉब्लम विद SGLT2 इज फंगल इन्फेक्शन और रिपीटेड फंगल इन्फेक्शन जेनाइटल इन्फेक्शन. उसके बारे में बहुत परेशान है. सो द टेक होम मैसेज शुड बी दैट एज फार एज पॉसिबल ब्लड शुगर शुड बी केप्ट 180 एंड डू ए रिपीटेड ब्लड ग्लूकोज टेस्ट. आप पेशेंट लेटा हुआ है आधा घंटे में आप ब्लड शुगर कर ली. But every half an hour you can do a blood sugar, and if the blood sugar is going up, you can put some amount of it. The question of insulin infusion. Insulin has to be given through a pump. अभी तक सर्जन्स क्या करते हैं कि 5% डेक्सट्रोज में 12.5 यूनिट डाल के और शुरू कर देते हैं. They think it is an insulin infusion. But remember that insulin sticks to the tubing, and if it sticks to the tubing, how much insulin is being given, nobody knows. So therefore, insulin is always given with an infusion pump. Now, how many nursing homes are there who have an infusion pump? And if they have an infusion pump, then who is monitoring that infusion pump? क्या हमारे anesthetists infusion pump लगाने के लिए और monitor करने के लिए सक्षम है? I don't think so. Even a single anesthetist मुझे आप बता दें जो कि infusion pump लगाता हो और monitor करता. लगाना तो बहुत सिंपल है. शुरू कर दिया. मॉनिटर कौन कर रहा है? Where is the glucometer in the surgical operation theatre? मुझे तो नहीं दिखाई देता है. And I talk to all the surgeons, I talk to all the gynecologists. मुझे नहीं दिखाई देता. Theoretically बिल्कुल सही है. आप बिल्कुल ठीक कहते हैं. लेकिन प्रैक्टिकली अगर हम देखें तो इस लेवल पे आने में हाँ ICUs में अब जैसे हमारे यहाँ इंटेंसिव केयर बहुत बढ़िया चलती है. इनकी एनेस्थेटिस्ट महोदय जो हमारे पास ही रहते हैं. लेकिन क्या वो डायबिटिक पेशेंट्स में ऐसा कर रहे हैं? मुझे तो बड़ा डाउट. कर रहे हैं. अच्छा क्या कर रहे हैं? इन्फ्यूजन पंप लगाते हैं. इन्फ्यूजन पंप और रिपीटेड टेस्टिंग. अच्छा और वो इंश्योर करते हैं कि 180 रहे. 180 के 120 और 180 के बीच में रहे. बट लेस देन 180. चलिए मुझे इट इज अ रिवलेशन टू मी क्योंकि आई नॉर्मली टॉक टू द गायनेकोलॉजिस्ट एंड टू द ऑफ्थल्मोलॉजिस्ट. बाकी तो शायद आई एम टॉकिंग अबाउट ICUs. ICUs. हाँ तो अब सर्जरी तो सभी कर रहे हैं ना. मतलब इंटेंसिव केयर तो अब ठीक है जो कर रहे हैं. सो देन इट बिकम्स ह्यूजली एक्सपेंसिव. एक टेस्ट आपका 50 रुपए का पड़ता है. अगर आप एक दिन में 10 टेस्ट कर रहे हो, 15 टेस्ट कर रहे हो, 20 टेस्ट कर रहे हो, 3 दिन 4 दिन लगातार कर रहे हो तो इट बिकम्स ह्यूजली एक्सपेंसिव. सो द आइडिया इज कि हाँ एक्यूट स्टेज में बिल्कुल ठीक. आई फुल्ली एग्री दैट इट शुड बी केप्ट 120, 180, below 180. ठीक. Anything anyone wants to add?
Thanks, Dr. Anshul, for delivering such a wonderful talk, and request our chairperson to do honor and felicitate Dr. Anshul Agarwal for delivering such a wonderful.
Wait, sir, wait.
And I request Dr. Anshul to present a memento to our And we are thankful to Dr. P.C. Gill sir for making us so successful.